Let's now transition to the next, or the second vertical from this morning, focusing now on care and assistance. This vertical addresses innovative approaches to improving care models, person-centered assistance, and pharmacological therapies. To begin with this first note for this vertical, it's my honor now to welcome Mr. Joan Camprodon, Chief of the Division of Neuropsychiatry at Massachusetts General Hospital and Harvard Medical School.
Thank you. So thanks everyone for staying, and thanks for the organization for inviting me to this very diverse symposium. To start us off on this care theme, in the spirit of the WMIF cluster that is very integrative across the neurology, mental health, aging spectrum, I want to talk about neuropsychiatry as this clinical space that integrates the clinical neurosciences. You'll see that I use neuropsychiatry almost synonymous with the clinical neurosciences, meaning, again, this clinical space that encompasses from neurology to psychiatry to other neuroscience-based specialties. We'll talk about precision medicine applied to neuropsychiatry, and that is this attempt to be very patient-centered and to develop medicine strategies that are individualized. So we're not trying to address population-based problems, but try to do that, but by focusing really on patient-specific issues, patient-specific treatments. And last, we'll talk about neuromodulation, this neurotechnology space that is very therapeutic in intent, that is a window that is bringing this precision medicine framework to the brain and to brain medicine. So these are my disclosures. So let's start by setting up the framework. And let's start first by setting up the biological framework. The brain is complex. I don't need to tell you that. And because it's complex, both studying it in health and studying it in disease leads itself to many different levels of analysis and approaches. So you see here this inverted pyramid that goes from the more microscopic to the more macroscopic. So you have genes that encode for molecules, molecules that make up cells, cells that connect with each other, define these kind of synapses, define microcircuits. These microcircuits define brain regions and what we think these brain regions do. These brain regions are connected into larger distributed circuits or brain networks. And then beyond that, you have the organ dynamics, blood flow, immunity, CSF flow. And then you have the brain functions, right? Behavior, cognition, emotion, movement, sensation. These are the functions that break down with diseases, and that when they break down, we call them symptoms. And when you have signs and symptoms, you have syndromes. This is what we address when we treat individual patients in the clinic, those of us who are clinicians. But beyond individual patients' problems, you have population-based problems, what epidemiologists study. And beyond that, you have even loftier topics like cultural, religious, moral issues, which I would argue are also relevant to study brain health and brain disease. So there's no one level that is more relevant than any other, but it's very important that we are aware of what is our level of analysis, because that defines the tools that we use to study the brain, but also defines the formulations, the explanations that we can generate with those tools. And I would argue that in neuropsychiatry and clinical neurosciences, the circuit level is a particularly relevant approach because the brain is an electrical organ. And behavior, cognition, and emotion, and movement and sensation, which are the clinical focus of clinicians working in this space, are actually computed at the level of circuitry, right? These are circuits just like the ones you have in your cell phone, your computer, just they're not made out of silicon. They're made out of protein, fats, and sugars. And instead of ones and zeros, they carry oscillations, but they also process or compute meaning, meaning being brain functions. And again, it's not to say that all the other levels are not relevant, but I would say they're relevant to behavior, cognition, and emotion, to the extent that they condition, that they determine those circuit dynamics. So dopamine at the molecular level is relevant to cognition, sure. Why? Because it conditions or it allows certain processes, certain computations at the circuit level. So our level of analysis, as we're thinking about these problems in neuropsychiatry clinically and in neuromodulation, both clinically in terms of treatment development, in terms of the technology, is going to be the circuit level. Now, beyond this more pathophysiological, mechanistic rationale for focusing on circuits, there's another more pragmatic and therapeutic rationale as well. So there's three main types of treatments in the clinical neurosciences in brain medicine. We have drugs, right? So the drugs intervene in the brain at the level of molecules. Then we have the non-somatic therapies. These are things like psychotherapy, like physical rehabilitation, like cognitive rehabilitation, like gait rehabilitation. And these intervene in the brain at the level of function. And again, the entry level, in a way, you could argue doesn't matter as much because all these levels are combined or are connected causally, bottom up, but also top down. So we have drugs, we have behavioral therapies, and finally we have devices, or brain stimulation, or neuromodulation. These are all synonymous terms. And these devices, these forms of treatment, intervene in the brain precisely at the circuit level. We're talking to the brain in its own language. Ones and zeros, oscillations, electrical patterns. So both from a more physiopathological reason and perspective, and from a more therapeutic, pragmatic rationale, the circuit level is a particularly relevant level of analysis. But how do we go from circuits to patients? We're not used to thinking in those terms clinically when we're addressing mental health problems. And it's a challenge, but there's an approach and there's a method to it, and we'll discuss it now. So this is, on the left, the way we traditionally define one of the most prevalent conditions, mental health, major depressive disorder. It's strictly phenomenological, right? There's no biology in here. There's a list of signs and symptoms, meaning subjective complaints and objective alterations that define the syndrome. Now, you can see there's a list of 9 signs and symptoms here. There's actually 227 different ways of combining them and meeting criteria for depression. So the heterogeneity is extreme, and it makes it very challenging to formulate depression at the biological level, at the circuit level. Part of the issue has been that we've been trying to, again, find the neural correlates of depression as a whole, depression in these 227 different ways. And this is a challenge, but it's a challenge if you're thinking that depression is a disease. And the question is depression a disease? And the answer is probably no, depression is not a disease. Depression is a clinical syndrome. In medicine, not just in brain medicine, but when you have subjective complaint and objective abnormalities, we define those clinical syndromes. And under any clinical syndrome, like left heart failure, for example, you have many different diseases that coalesce into that shared presentation. So in the case of left heart failure, you could have hypertension or pericarditis or myocarditis or an arrhythmia or a valvular disease. All those different diseases lead to left heart failure. That's the syndrome. But they're very different diseases that require very different treatments. In depression, though, we've been operating at this level of just syndromes. So what we need to do is dissect the syndrome into its core units of behavior, cognition, emotion, autonomic function, if you want. And once we start thinking about it in those terms, then the exceptionality of psychiatry, mental health, in a way, disappears because it's just the same approach that we use in the rest of medicine, not just brain medicine. So how do we go not just from depression to the brain, but from its core units, its core dimensions to the brain? So you'll see that I'll be talking about circuits through the talk, but now for visualization purposes, I'll be pointing to specific nodes, which are hubs from these circuits. So we talk about depression being a mood disorder. There's excess of negative emotions. There's this node here, the subgenual cingulate, that is particularly relevant in that sadness, in the languishing. We know that in patients with depression, this area is hyperactive. We know that someone who does not have depression will induce sadness, activity goes up. We know that the cells, the composition, the structure in this area, if you have depression, changes. And this has been the target for deep brain stimulation, meaning surgical treatments, neuromodulation treatments in brain medicine for depression. But depression is not just excess of negative emotions, it's also deficit of positive emotions, what we call anhedonia, the incapacity to enjoy things, the incapacity to motivate, to do things that we like, that are pleasant. And we used to think that there was a single continuum of emotions, negative emotions on one side, positive emotions on the other. Now we've learned that actually there are two distinct continuums with different anatomy, with different physiology, with different clinical implications, with different therapeutic implications. So this is a mid-sagittal cut, meaning in the middle of the brain. If we were to move a little bit to the left or to the right, we'd be in the nucleus accumbens, which is a key region of these reward pleasure networks, which are critical for anhedonia. But again, beyond mood and emotions, in mood disorders, which are of course relevant, we have other types of problems. We have behavioral, we have cognitive, we have autonomic, so this lack of energy in this ascending reticular pathway. We have problems with sleep and appetite, the more kind of core autonomic functions in this hypothalamic nuclei. We have core problems with attention, cognition, executive function. We have this dorsolateral prefrontal cortex circuits that go frontal parietal and from the cortex down to subcortical structures. We have rumination and guilt, and pointing here to the posterior cingulate cortex, part of this default mode network that processes information out of the inner self when it's adaptive, but also when it's maladaptive. And finally, we have self-harm and suicide, which is probably much more complex than the other dimensions, but there's lots of evidence pointing to this region, the anterior cingulate, as a key area that carries a signal that changes in suicidal patients as a function of severity, as a function of the lethality of the means of attent, etc. So when we look at this graph, one thinks that there's no wonder that we fail so miserably at finding the neural correlate of depression, because it's all over, right? It's very distributed. But again, these specific dimensions have a level of biological validity that is much more precise and accurate and valid than if we try to find the overall neural correlate of depression, one. And two, these dimensions are present in depression, but they're not only present in depression. You have anhedonia in Parkinson's disease, in traumatic brain injury. You have problems with sleep and appetite in, again, Parkinson's disease, in many other psychiatric conditions. You have problems with executive function pretty much in any psychiatric and many neurological conditions. So if you formulate a solution to these dimensions in depression, you may very well have a solution that is transdiagnostic, that is not only crossing the line between one condition to the other, but it's also crossing the line from neurology to psychiatry. Once we start thinking about these clinical problems at the circuit level, these distinctions of what's psychiatric, what's neurological, really fade away. And not only at the theoretical academic level, but a very pragmatic and therapeutic level, as we'll discuss right now. So we've talked about the biological framework, we've talked about the clinical framework, and this is the technological framework. Devices, neuromodulation, brain stimulation, therapies. It's important to highlight that there are many techniques, and that this is one way to classify them. So based on their safety or tolerability profile. So we have the surgical or invasive techniques, things like deep brain stimulation that you're seeing down here. We have the convulsive techniques. These are techniques that do not require surgery, they don't require anesthesia. Sorry, they do not require surgery, but they do require anesthesia and general paralysis. These are things like electroconvulsive therapy or ECT, was the very first neuromodulation technique that we developed and remains one of the most effective treatments for treatment-resistant depression, particularly in the context of suicide or psychotic depression, also for other conditions like bipolar disorder, schizophrenia, catatonia. So we have invasive, we have convulsive, which again is not surgical, but yes, requires anesthesia, and then we have the non-invasive techniques. These are techniques that do not require surgery, do not require anesthesia. They're the best tolerated. They're generally either ambulatory, meaning you do it in the clinic, but some of these models, some of the techniques also can be done at home. Patients can just drive themselves or walk or take public transportation or bicycle the way they want, and they can come back. They don't need to be chaperoned. And because of their safety patterns and tolerability profiles, they have the largest indications, right? And here you have transcranial magnetic stimulation, which is what you're seeing here, and we'll discuss it a little bit. This is the regulatory profile, at least in the US based on the FDA, meaning what techniques are approved for what indications. And you see that deep brain stimulation is approved for chronic pain, was actually the first indication, eventually was revoked. Then we have movement disorders, Parkinson's disease, essential tremor, dystonia. Then you have obsessive compulsive disorder and epilepsy. You start seeing that these are not neurological or psychiatric treatments. These are circuit disorder treatments. And because both neurological and psychiatric conditions are circuit disorders, you can use them for neurological and psychiatric conditions, because those terms are starting to be less meaningful. Then you have VNS, or vagal nerve stimulation. It's also a surgical technique, but doesn't require a craniotomy. We don't have to get into the brain. We use a highway to the brain, which is the left vagus nerve. And again, it's approved for epilepsy, for major depressive disorder, and for stroke rehabilitation after the spin paralysis of the arm, so motor recovery of the arm. Again, very distinct, very diverse clinical problems. They all share this capacity to be formulated at the circuit level. And then we have TMS, which is approved for depression, for migraines, for OCD, and for smoking cessation. So you see that this notion of neuropsychiatry, this notion of the circuit approach to patient care, to patient case formulation, is starting to move beyond just a theoretical model into very pragmatic treatments that we can use in the clinic, and that more and more are being used not just in academic centers, hospitals like mine, but actually in community settings and private practice settings. All of these techniques, while yes, they're different technologically and clinically, they do share a core framework for technology, biology, and clinical care. They all require that you have to know three things when you're going to be using them. You have to know what is the brain circuit that you're trying to engage and modulate. This is going to be determined by the pathology you're treating. If you're treating OCD or depression or smoking cessation, well, the circuits that are affected by those conditions are different, so what you need to do to the brain to get that patient well is also different. Then you need to know the target that gives you access to that circuit, right? By definition, circuits have many different nodes, and they're all interconnected. But you don't have to directly engage them all to change the circuit. Because they're interconnected, if you change one of them, you change, yes, physiology, activity in that node, but you also change how this node is talking to all the other nodes. So again, you choose one target, and that's a window that gives you access to engage, to modulate the entire circuit. But the goal is not to change that one target, is to indeed change the circuit dynamics. So know the circuit, know the target, and finally you have to know the direction of modulation. What do you need to do to get that patient well? Do you need to increase or decrease the excitability of some nodes? Do you need to increase or decrease the connectivity, how well these nodes talk to each other? Do you need to increase or decrease the gamma frequencies or beta frequencies? There are specific frequency ranges that the brain uses to compute. It depends on how you formulate the response biomarker, how you formulate the pathophysiology, the disease mechanisms. But you have to know what is the physiology within the constrained anatomy of a circuit that you want to change through this target. And again, this is a framework that is shared by surgical, convulsive, and non-invasive techniques. And the fact that you have this shared framework defines the space of neuromodulation as a novel clinical subspecialty, if you want, within brain medicine, again, across neurology and psychiatry. So this is the framework, biological framework, is a circuit neuroscience approach. The clinical framework is moving beyond syndromes, starting to think about dimensions in patients. And the technical framework in neuromodulation is this kind of spectrum from invasive to convulsive to non-invasive. And the question is, how or can neuromodulation bring this precision medicine framework, this specialization or individualization approach in patient care to the clinical neurosciences, to neuropsychiatry? And you would do that by, again, knowing the circuit, the target, and the direction of neuromodulation, but not for depression or OCD or bipolar disorder or schizophrenia, but to that one individual sitting with you in the clinic with a specific set of signs and symptoms. So how do we do that? How do we develop these individualized tools? Well, the framework for treatment development is, again, focused on circuits, and is that any brain function or any brain disease, in fact, any brain computations, can be defined at the circuit level. And that means understanding the anatomy, what are the nodes, where they are, understanding physiology, what's happening when, and behavior. What is it that these circuits are computing? Emotion, cognition. If you can formulate a clinical problem at the circuit level, then that clinical problem is a potential target indication for device neuromodulation therapies. And the process to develop those treatments is not new. Maybe it's new how we've been using it in this clinical space, but this is how we do it in the rest of medicine. First, you understand pathophysiology, meaning the disease mechanisms. In this case, again, focus on circuits. You have to know the anatomy, the physiology of the circuit, and the behavioral computations of the circuit. But understanding these mechanisms is not enough. You also need to develop biomarkers. These are signatures, biological signatures, that have clinical information, that help us make decisions. And there's different types of biomarkers. You have disease biomarkers that tell you whether you do or you do not have disease A, severity biomarkers, if it's a more severe or less severe form of it. Prognostic or predictive biomarkers is a signature now that tells me something about the future. You will or you will not respond to a treatment. You will or you will not develop side effects. These are all signatures that may help us make decisions in the clinic. But then you have response biomarkers, and these are not so helpful in the clinic, but are very helpful in developing treatments for the clinic. These are signatures that are dynamic, they change, they vary, and in their biological changes, they carry with them, they explain the clinical changes. If we understand these response biomarkers, if we can identify them, then we can start developing treatments in a much more rational way. Serendipity or luck has been very good to psychiatry. We have many treatment options, luckily, for patients. And we've been able to do this despite having limited understanding of very difficult biological and clinical problems. That said, serendipity has kind of gotten us stuck for a number of decades, and changing the approach is necessary. And changing the approach means doing bottom-up treatment development, from biology to clinical options. So this is general framework, okay, but this is a population-based framework, if you want. This is not precision medicine. It's necessary for precision medicine. It's necessary for individualization, but it's not enough. So what is precision medicine, or in this case, precision neuropsychiatry? So the key concept here is individualization, right? So we want to treat patients, not just diseases. And this idea that one size fits all, meaning disease-based therapies, is moving towards a patient-specific protocol. The issue here that we're trying to address is heterogeneity, not just clinical heterogeneity. I told you that there were 227 different ways of meeting criteria for major depressive disorder. You can have two patients who don't have a single symptom in common, and we may say they both have the same condition, right? We're trying to move away from this heterogeneity, but also from the fact that normal, healthy brains are not the same from one healthy person to the other. There is normal anatomical, physiological, molecular variations. And unless we take all of that heterogeneity into account, our impact, our efficacy is going to be limited. So we need to incorporate that information into our treatment planning, which means we have to measure, and we have to understand, and we have to adjust to the patient-specific features. But again, precision medicine is not just about individualizing specific treatments. It's also about individualizing choices or decisions about treatment selection. We may have the good old treatments that we all know work, but we just don't know what works for whom when, right? So, and up to now, the way we choose medications, for example, for many of these patients, is by empirical trial and error approaches. We use one, we use clinical common sense that it's going to be safe and reasonably effective. If it doesn't work, we use another one. If it doesn't work, we use another one. But there's very little evidence base into that whole process. We need to develop algorithms that are capturing information about those patients and let us know, okay, you have depression, but given your demographics, given your behavioral patterns, given the biological measuring, given sensory information about your day-to-day activities, you are more likely to respond to treatment than that treatment. and use that evidence-based algorithms to support decisions by physicians when they're dealing with individual patients. So again, there's two layers of individualization of precision medicine. One is developing individualized treatments, but two, also developing individualized treatment selection or treatment allocation strategies. So if that's the framework, how do we develop novel treatments? Well, again, the emphasis and why I'm talking about circuits so much is because that's going to be the framework to understand all of these problems, right? So if it's about behavior, anatomy, and physiology, then you individualize by capturing behavior, anatomy, and physiology. So you could do things like controlling the where, meaning knowing where, for example, you have to place the electrode or place the neuromodulation coil for that individual in particular. Not having a solution for depression or for OCD, but having a solution for you, which may be different than for you, and that may be through doing image-guided therapy, right? Capturing the anatomy and the activations and those circuits for that individual and using that information to select the right target. I'll discuss some examples in a minute. You can also individualize physiology. So not just the where, but the when. So at what time you have to stimulate, what specific frequency you have to use. Again, it may be different from one patient to another. And some examples here are using EEG, which is another brain technique that we use to diagnose epilepsy sometimes as well, and other conditions. But it's very good with telling us the timing of specific brain events. So we can use that to help us guide the specific intervention. And last, also behavior, we can use strategies like behavioral therapies combined with neuromodulation, or even virtual reality-based behavioral interventions that allow us to control the state and put it in a specific brain state. And in that only brain state for that individual, we apply the stimulation. So again, you control the anatomy, the physiology, the behavior by measuring and individualizing the intervention. And that leads us to, in this case, precision neuromodulation. And this is the treatment selection algorithm. Briefly, the way we use to select treatments is, you have disease A, I give you treatment A. We're moving to a more precision model, which is based on the biological, demographic, clinical features that I'm selecting. I'm going to develop a biotype, and based on this biotype, I will select the best treatment for you, which may be different for someone else who has the same diagnosis. All right, so with this general framework, let's talk about some specific examples of how we can leverage anatomy, physiology, and the state. So we'll talk first about anatomy and the use of individualized MRI-guided TMS, or transcranial magnetic stimulation. What is TMS? TMS is a neuromodulation technique. It's a non-invasive neuromodulation technique, which basically was developed in the mid-'80s, early '80s, and is a medical application of Faraday's electromagnetic induction principle. We have a coil that has an electric current flowing through it. It's a circular coil. And Faraday told us that if you have a circular circuit and you have electricity flowing through it, it will generate a magnetic field. The magnetic field will move away and will decay with the square of the distance, will become weaker. And that magnetic field, one of the properties is that if it moves in space, it interacts with materials that are not conducting electricity, like wood, like plastic, it would just go through them, unaffected, unimpeded. But if that magnetic field interacts with a material that conducts electricity, like a piece of wire, for example, it will convert back to electricity. It will go from a magnetic field to, again, an electrical current, electrical field. So if you apply this from the physics labs to the TMS clinic, we have a circular coil like this one here, and we have electricity flowing through it. So it generates a magnetic field. The magnetic field goes towards the intracranial space, and it interacts with the skin, with the muscles, with the bone, with the meninges, which is the skin around the brain, with the CSF, which is a fluid under the meninges. And those materials do not conduct electricity, so the magnetic field just goes through them unimpeded. But then it touches the brain, the cortex, the neurons. Neurons do conduct electricity. So then that magnetic field converts back into an electrical current, and that electrical current can activate those brain cells. So although we call it magnetic stimulation, it's a bit of a misnomer. It's actually electrical stimulation, but we use this trick of physics to spare a craniotomy, to spare having the need to open the skull and expose the brain, and still non-invasively apply a very focal pattern of electrical activity. This use in repetitive cycles can be used to increase or decrease the activity of the brain, can be used to induce plasticity, meaning changes in brain computations. As of today, it's been approved as a treatment for depression, for migraines, for OCD, and for smoking cessation. But again, all of these conditions are different from each other, and anatomy is key because the target for depression is this one, what we call the dorsolateral prefrontal cortex. The target for OCD is in the midline. It's what we call the dorsomedial prefrontal cortex. The target for migraines is in the occipital pole, in the back of the brain. The target for smoking cessation is in the ventrolateral, meaning the lower part of the frontal lobe. So you have to know where you are, because otherwise you're not going to be effective. And the good thing, one of the good things about TMS is that it's non-invasive, and one of the bad things about TMS is that it's non-invasive, because it allows you to be very focal, yet you're not seeing the brain because you don't have an open craniotomy. So you need technology to help you with precision. We have neuronavigation techniques, which are stereotactic technologies that basically allow you to have a brain scan from that individual from before your TMS session. And then with this technology, you can co-register your coil to the brain scan. And as I'm moving the coil around the head of the subject, I can see on the screen precisely what part of the brain I am stimulating. And I can use different types of MRI techniques. The one that has had more traction clinically is functional connectivity MRI, which allows us to define brain networks non-invasively. So I told you earlier that the subgenual cingulate, which is this green area here, is a very important node in depression. And the question is, well, what's the network around that node for that individual patient? So I can capture resting state fMRI from that individual, and I can define that seed and ask the brain, tell me, or through analysis of this data, tell me how well are different areas of the brain connected to that node. And for that individual, I can choose the specific area that has the highest connectivity, which means it's firing together, meaning they're connected together. And if they're optimally connected, means that by stimulating this superficial node, I have preferential access to this deeper structure. And if I can do this, then I can define individually for every patient the specific target for stimulation. And we run a trial, small open-label trial, where we implemented this approach, individualized approach, and we saw that we had a 50% of patients who did not respond, but then we have 50% of patients who responded. And interestingly, out of the 50% of patients who responded, they all remitted, meaning it was an all-or-nothing type of response. If we got it, it was a home run, meaning I got you all the way out of the depression, and if we didn't get it, then you didn't really respond. And again, the standard responses with TMS without individualization are about a 50% response rate, meaning you at least get 50% better, which is similar to this, but it's about 25 to 30% remission rate, which is a lot worse than this. So by using this individualization, we could improve our outcomes. And to contextualize this clinically, these are patients who had failed 7 different medications in that episode. These are patients who were very sick, very refractory. And we know from research that has been done from the STAR-D trial, which was the largest clinical trial that has been done on depression, which basically randomized patients, actually didn't randomize patients, identified patients with depression who were naive to treatment, and they gave them one medication. And if they failed that medication, they gave them a second one. If they failed, they gave them a third one. If they failed, they gave them a fourth one. And one of the things that this STAR-D trial showed is that the more treatment-resistant you are, the more treatment-resistant you are. So patients who were naive to medications, 28% of them remitted. If you fail one medication and you're given a second one, only 21% remitted. If you failed 2 and you were giving a third, only 16% remitted. If you failed 3 and you were giving a fourth, only 7% remitted. TMS has been approved for patients who have failed 1 or more medications, but in clinical practice, we are treating patients who have failed 4 or more medications because that's the way insurance companies are covering it, at least in the United States. So we're working at the right of this graph, and yet we're having remission rates of about 30% with traditional non-individualized therapy, and we can get to 50% based on individualization. But this gets even better. Recent developments have done 2 things. One, develop cerebral stimulation, or TBS, which is a protocol that takes only 3 minutes to stimulate the brain in the right way. So we used to have sessions that lasted 38 minutes, and colleagues developed this protocol that showed that biologically it had very similar effects to this 38-minute protocol, but only in 3 minutes. And this group of Canadian colleagues across 3 hospitals asked the question, well, if they're biologically the same, are they clinically the same? And they compared this 38-minute protocol with the 3-minute protocol. So basically, patients with depression were randomized to receive either the 3-minute sessions or 38-minute sessions. And they show that they're both equivalent, right? They have a response rate, again, 15% improvement or greater, of 39 to 49%, and a remission rate, meaning depression goes away, of 20 to 32%, which are similar rates to what we have in the clinic. This is not individualized, but this got us to get FDA to clear this rapid approach to TMS. And once you have sessions that are so short, they're only 3 minutes, the question is, what do? You have patients come in, and they drive through traffic, they arrive, they spend 45 minutes, 1 hour, they sit in for 3 minutes, and they go home. Well, that's one option. Another option is to play with this timing and do more in every session. So instead of a 3-minute session, you could do a 9-minute session. This is equivalent of 3 sessions in just one. It's still very short. So you have 3 sessions in just one, but what if you do that 10 times in one day? Right? You have a 9-minute session, you wait an hour, another 9-minute session, then you're basically packing 30 sessions of TMS in just one day. That's the equivalent of 6 weeks of TMS in one day. What if you do this 5 days in a row? It's the equivalent of 8 to 9 months of TMS in just 5 days. So this has been shown to be, 1, safe and well tolerated, but B, not only very effective, but rapidly effective. So the same protocol that was approved in 2022 basically is an image-guided, accelerated TMS protocol. It's the first treatment approved by the FDA in mental health, in psychiatry, that uses a biomarker. And that is an individualization precision medicine biomarker. So there's 2 components, 2 ingredients to this treatment. 1, the massive dosing that I described earlier. But 2, the fact that they're using functional connectivity guidance to individualize the targeting, the location of the coil. And with this accelerated and individualized approach, they describe 85% response rate and 78% remission rate. These are not numbers that we're used to in treatment-resistant depression. So it's generated a lot of very healthy skepticism. Moreover, these are not just very high numbers. This is happening in 5 days. We used to think that it takes 6 weeks or more to treat depression. Well, it's actually not true. You can do it in just 5 days. You can do it in less, too. So these data are now being replicated in other centers, are now starting to be used in community settings, also, of course, in inpatient units, right? You have a very acute patient who is hospitalized, maybe with suicidality, after suicide attempt, maybe just with very bad depression, and you have a treatment that in 5 days can get you well at an almost 80% rate. Well, that's an optimal option for those patients who are in the most acute settings, like an inpatient unit. And this was approved 2 years ago. And this is just, again, one more of a series of treatments that we have now that have challenged our idea of depression and what it takes to treat depression. A series of treatments that are rapid antidepressant treatments, right? We have fMRI-guided TMS, we have ECT, which remains a pretty rapid treatment, 2 to 5 weeks. We have esketamine or ketamine, a pharmacological treatment that also can treat depression in just 1 day. Effects go away quickly too, but they come on quickly and you can have maintenance effect. They're also particularly effective for depression with suicide risk. Neurosteroids for postpartum depression, and psychedelics, which are in development. We still have to build the evidence, but they're looking good so far. Now, the question now is who should get what and when? And this is where those AI algorithms that help us select treatments become very helpful. So let's move from depression to a more neurological condition, Alzheimer's disease, and to focus more on physiology. So historically, and still today, I would say, we've thought of Alzheimer's, we just heard about it in the first intervention, at the cellular and molecular perspective, right? So Alzheimer's is basically abnormal proteins, amyloid and tau, that build up, they generate inflammation, and that generation leads to neurodegeneration. So because we think about a cellular and molecular level, then treatments are responding to that. So they're pharmacological or biological therapies. So pharmacological or immunotherapies. Now, we've developed, as we heard, recent immunological therapies that are very effective in clearing the amyloid, not that effective to changing the disease. So we used to think this would be a disease-modifying treatment. Maybe not so much. And that's challenging not only how well these treatments work, but actually our very notions of what causes Alzheimer's disease. An alternative formulation is to move beyond the molecular and cellular and go to the circuits, go to physiology. There's been evidence showing that in Alzheimer's disease, you have deficits in fast oscillations, what we call gamma oscillations. And we can think or formulate the problem at the circuit level, then we can again come up with a device-based therapy. So there's different types of brain waves, slower waves, faster waves. They all have fancy Greek names. And we know that in Alzheimer's, you have a decrease in gamma waves, particularly around 40 hertz, meaning 40 oscillations per second. And work by our colleagues at MIT across the river from me have shown that if you apply 40 hertz interventions, but just with light and sound, to rodent models of Alzheimer's, you actually improve memory deficits and you improve the bad oscillations. But actually, you do clear amyloid, you reduce inflammation, and you stop neuronal cell death. So this is pointing to potentially being a disease-modifying therapy in humans as well. But we have to test it. So there's been work being done with this, it's called GENUS, which is gamma entrainment using sensory stimulation. So again, visual or auditory stimulation at 40 hertz in patients with Alzheimer's mild cognitive impairment. And they've shown that you can improve the physiology, so the abnormal gamma oscillations. You're improving memory function, which is the most important improvement, but you also seem to stop changes in brain volume that we see in Alzheimer's and to clear amyloid and tau. So again, this is looking like a disease-modifying therapy in Alzheimer's. The question is, if what we're trying to change is the electrical phenomenon, why use sensory and not just electrical interventions? So electrical stimulation, and if we can, to do it at home. So for that, we've been using transcranial electrical stimulation, which is one more of these techniques that is using a very simple technology. It's pretty much a 9-volt battery with a cathode and an anode that you put on the head, and you can do different things with that. You can apply direct current, or you can apply alternating current. If you apply alternating current, you can choose what's the frequency of the alternating current. And again, you could choose delta frequencies, theta frequencies, also gamma frequencies. So if in Alzheimer's we have this decrease in gamma frequencies, particularly 40 hertz, well, can we apply 40 hertz TACS, 40 hertz electrical, not just auditory stimulation, in that context? So this is part of the work that we've been doing. Now, there's a traditional approach, the non-smart approach, some will call it, which is the open loop. And that is, I know I want to change the 40 hertz rhythm in the brain. I'm going to apply a 40 hertz rhythm to it, and I'm just going to measure it out at the end. But this approach is blind to what's happening in the brain of that patient. The alternative, more complex but precision approach is to do a closed-loop system, where we actually are measuring brain oscillations in that individual. And we're choosing the peak frequency, because it could not be 40 hertz, it could be 38 or 41 or 43. But also, we're measuring the specific timing, and we're synchronizing our stimulation to the specific timing and oscillations in that brain. That is the precision approach, and that is one that is still in development, but is starting to show promise to be more precise and more effective. And last, we can use this at rest, meaning you apply the stimulation and you're doing nothing, or you can do this while you're forcing the brain to be in a specific state. These are the combination therapies, where you're applying TMS, for example, in the context of cognitive rehabilitation, or physical therapy or psychotherapy to enhance treatment. And you can do this by traditional means, but also it's being developed as a VR-based intervention. VR-based cognitive rehab or physical therapy or psychotherapy. And there's applications in PTSD and pain, which have been quite successful. So we'll wrap it up here. Again, we've talked about precision neuropsychiatry neuromodulation. The idea is having this patient-specific circuit-based approach that moves beyond diseases or syndromes and starts to analyze or identify patient-specific signatures. We want to address the biological and the clinical heterogeneity. It forces us to find biomarkers Yes, but by doing that, we can do biomarker-informed treatment development. And again, the focus is on circuits, again, anatomy, physiology, and behavior. This leads us from precision neuropsychiatry to precision therapies. And I've given you 3 examples, individualized MRI-guided TMS, or EEG-guided TACS, or combinations of TACS and cognitive rehabilitations. And finally, this approach about developing decision support algorithms for clinicians, often using lots of information and AI-based analytics that help us provide tools for clinicians so they can make better choices for their patients. So we'll end it up here. Thank you so much. This is the group that makes all of this work possible. Thank you.